Next up, we're going to talk about the mostly liver enzymes. In particular, alanine aminotransferase and serum glutamic pyruvic transaminase. So these are found in the liver, myocardium, muscle, and kidney. They're released 8 to 12 hours after a tissue injury. They peak 24 to 36 hours after that injury, and ideally with treatment will decrease by 4 to 6 days. And we see high levels, especially of ATL or ALT. ATL is Atlanta. Uh, ALT with myocardial infarctions, that's MI, but especially liver damage due to drug toxicity, alcohol, or some form of disease. We also see this elevated in non-alcoholic fatty liver disease or NAFLD. Often with ALT, we also look at AST, which is aspartate amino acid transferase. It's also found in the kidney, myocardium, skeletal muscle, and liver. And it also increases with liver damage, drug toxicity, or disease. So next up, we have the pancreatic enzymes, and we have amylase. You should know amylase already. There are two types. We're talking about pancreatic, but please remember where the second type of amylase is. It can be found in the pancreas, liver, and salivary glands. So an interesting note, obviously not going to be on a quiz or anything, but dogs have salivary amylase, so they have it. But cats, who are obligate carnivores, do not have salivary amylase. So dogs are able to eat carbohydrates. Cats, not supposed to eat carbohydrates. And when we see elevated pancreatic enzymes like amylase, this is an indication of pancreatitis. Although they can be elevated in around 10% of the cases. So if someone is presenting with high amylase, you can check other metrics to see if they're having pancreatitis. Often this will have a fever, pain in the area, something like that, but it can also come from bowel obstruction, salivary gland disease, a myocardial infarction, cholecystis, or a perforated ulcer. It's also elevated in individuals with bulimia, and this may be due to the salivary component. So our other pancreatic enzyme we can look at is lipase. It's found in the pancreas. It increases with pancreatitis. It rises 4 to 8 hours after symptoms. So if you saw high amylase, a way to check if it's pancreatitis would be to then check lipase as well. And this is a sensitive and specific marker of acute pancreatitis, unlike amylase. And it will remain within normal limits in non-pancreatic conditions. So this is the most important part here. Elevated lipase and around 3 times the level of amylase is an indicator of alcoholic pancreatitis. So very few people think about pancreatitis related to alcohol. They usually think of the liver, but prolonged alcohol consumption above the recommended limits can also lead to pancreatitis. So now we're going to move away from our enzymes into important disease markers. They're kind of all grouped together because these aren't a vitamin or a mineral or an enzyme. So we're going to look at glucose, glycosylated hemoglobin, also called HbA1c, blood urea nitrogen, usually just called BUN, uric acid, and creatinine. So blood glucose. This is the glucose that we have in our blood. Uh, this is very tightly regulated. Oops. Think about all of the hormones that regulate glucose. Insulin, glucagon, cortisol, and even the adrenal hormones, like norepinephrine, epinephrine balance. So when you have a bunch of hormones regulating one thing, it is very important. We regulate things that are super, super important. Glucose being possibly the top. So blood glucose, as you're all, I'm sure, aware, is elevated after a meal. Sometimes we call this postprandial. So fasting and postprandial concentrations will be elevated in diabetes and severe stress. So elevated glucose is called hyperglycemia. Notice that I didn't say what type of diabetes. It'll be elevated in type 1, type 2, GDM, and in it may be in insipidus, but that's more with the urine. When fasting, we usually have a low normal. If we do not have a pathophysiology, it won't drop below normal. That's because it's so tightly regulated. So hypoglycemia is rare, except in type 1 diabetic, people with type 1 diabetes. So again, this would be the pathophysiology. And so even though people will say, oh, I'm just angry or hungry because I have low blood sugar, hypoglycemia is very rare, and often we don't even detect it. Think about in type 1 diabetes. People with type 1 diabetes are at risk of hypoglycemia, and their risk of going into what's called diabetic coma due to hypoglycemia. And so this is why they have to be very careful with their insulin. They're constantly monitoring their blood sugar. And they are making sure that the glucose they do consume goes into the cells by exogenous insulin. But we see from data that glycemia is difficult to control exogenously without something like an artificial pancreas. So if we were able to detect hypoglycemia, we would not see as many hypoglycemia related complications in people with type 1 diabetes. This is just a long way of saying we don't detect our own blood sugar through cognitive methods. So next up, we have hemoglobin A1c. This is very related to blood glucose. This is an average indicator over plasma concentrations over the previous months. In fact, it's over the life of a blood cell. Which is around 3 months. It's formed in a non-enzymatic glycation of hemoglobin from exposure to blood glucose. So passing red blood cells have high glycation after sugary food intake. And this is a question. So do they? So that's one of the questions But basically, what we know is it's not after just food intake. This is prolonged exposure to sugar, to hyperglycemia. So let's think about our red blood cell. This is him. He looks like a little donut, kind of. You know, they have like a little indent part. So this is our red blood cell. Normally, we have sugar all around. Well, we have around 5 milliliters of sugar in our blood. And we'll make some cell walls. This sugar is transported into the cell with the help of our GLUT4 receptors. And GLUT4 receptors come to the cell surface due to insulin signaling. And in the muscle, contraction. AKA exercise. So if insulin is working, or we're exercising a lot and insulin is working, our red blood cells will have a normal amount of glucose attached. Just a normal amount. I like to think of our red blood cells, they're like little donuts. The amount of powdered sugar on your donut, that's your HbA1c. So now let's think about when insulin signaling isn't working, we don't have as many GLUT4 receptors. So sugar stays in our blood for much longer and more of it stays in our blood. So the longer we have excess sugar in the blood, the more sugar will get attached to the red blood cells. Thus, the higher HbA1c means the longer we've been exposed to excess sugar. Now, whether it's hyperglycemia or not, we can't necessarily determine. Let me erase this really quick. So, because of this, we have diagnostic standards for diabetes based on HbA1c in adults. So if the percent of HbA1c is less than 5.7, you are in the normal or recommended range. If you have slightly elevated HbA1c between 5.7 and 6.4, you're in the pre-diabetes range. This is a lot like being overweight. It means that you don't have diabetes, but you're at high risk. Most people with pre-diabetes will go on to develop diabetes. And then an HbA1c greater than 6.4 is an indicator of diabetes. You will need to know these percentages. I recommend just memorizing them. So let's look at the structure of hemoglobin and glucose. So recall, hemoglobin is what is making our red blood cell red. And our red blood cell is our little donut, powdered sugar donut. So here's hemoglobin. It's made up of a beta and an alpha chain. And because these are proteins, they have a nitrogen terminal value. This nitrogen can then, through what's called a Schiff base, attach to glucose. So essentially, the oxygen and H2O go by, become water, and this carbon attaches to the nitrogen. So this is a glycolated hemoglobin. So we're measuring what percentage of our hemoglobin is glycolated. So this is just a little extra step that basically this double bond, oops, uh, sorry about that, but basically this double bond, the hydrogen moves. So then we have a single bond with a hydrogen. This is more stable. You don't need to know the OChem, but it's good to know how the sugar is attaching to our red blood cell donut. So again, we're measuring how much sugar is on our donut. So the limitations of HbA1c. Some things can artificially lower it, increase hemoglobin turnover. So that would be from something like acute blood loss, hemolysis, sickle cell, thalassemia, recovery from iron, B12, or folate deficiency. All of these are going to impact how long our red blood cells survive. So this is red blood cell survival. Also, chronic kidney disease. So erythropoietin, that it will that will generate more red blood cells. And that means that we may just be putting in more red blood cells than we actually are supposed to have. Additionally, pregnancy, because blood volume increases, and cystic fibrosis, and it's because a variety of things are going on in cystic fibrosis, but a lot of enzymes aren't working. So if we artificially increase our blood volume or our red blood cell volume, or if we make it so that red blood cells don't survive as long, so they have to turn over quicker, we'll see lower HbA1c. When we see decreased hemoglobin turnover, such as in iron, B12, folate deficiency, or anemia, in the third trimester of pregnancy, so this is when we are, a lot of women are producing a lot of sugar because this baby's getting big. But it also can be due to an analytic interference, increase red blood cell width. So think about what will increase red blood cell width, and also generally just increased age. So red blood cell width is a numerical measure of the size variability of circulating erythrocytes, and we will get into that more. And keep in mind that the life of a red blood cell for men is around 117 days, and it is lower for women around 106 days. Think about what could be decreasing this by 11 days. You should be thinking menstrual cycle, menses. So moving along, we have bilirubin. We have two forms. The first is non-conjugated or indirect, and this is elevated when the liver is unable to conjugate it, thus too much non-conjugated, or excessive hemolysis. This is red blood cell death. But basically, the red blood cells look like this, and in hemolysis, it's like they pop. Conjugated or direct is elevated when the liver is unable to excrete due to obstruction in the bile passage. So It's able to conjugate the bilirubin. It's not able to get rid of it. So bilirubin makes up the major pigment in bile, so it's also what colors our bruises. And it's made from the breakdown of red blood cells and released into the blood. The liver takes it up, conjugates it, and releases it into bile. So we break red blood cells all the time. Runners in particular break red blood cells by running. So distance runners tend to be at risk for anemias because they're just breaking their red blood cells more. But there is normal breakdown of red blood cells, and that's where we get our bilirubin. Because bilirubin has a color, it's kind of like a sickly green-yellow color. When you have too much bilirubin, you yourself look sickly with a green-yellow color. This usually first appears around the eyes, but can become severe and the skin will become discolored. We also often see jaundice in newborn babies. This is because their liver just isn't quite online yet. So they have excess bilirubin just because all of their little tiny organs are starting to live on their own, and it usually resolves in a couple of days. They're usually exposed to UV light to help break down the bilirubin, but they will also be a little bit yellow when they're born. So hyperbilirubinemia in adults, this is any level above 170 micromoles per liter. Like I mentioned, in newborns, it tends to be elevated around 340, and it's critical when it's around 425. So again, just to remind you, if you're like, I don't remember what bilirubin is, when heme breaks down, heme being part of the red blood cell, so a macrophage, white blood cell, breaking it down, it breaks it into biliverdin. Guess what? This has a green color. And biliverdin then goes to bilirubin. And then this goes into the bile duct, where it is then released into the intestines, and this has a brown color. And that actually colors our poop. So we see mild rises due to hemolysis. We see moderate rises due to a variety of pharmaceutical drugs, but also in individuals with hepatitis, people on chemotherapy, and people who have a biliary stricture or something that is impeding the bile duct. We see very high levels in neonatal hyperbilirubinemia. And if someone has an unusually large bile duct obstruction, this could be a stone, a tumor. It's mostly a stone or a tumor. And we see very high levels with severe liver failure with cirrhosis. And this is most often related to substance use. So BUN and creatinine. BUN is blood urea nitrogen. Urea is the end product of protein metabolism, and it's the primary way that we get rid of nitrogen. If we didn't, every time we used protein and broke it down, we would poison ourselves with too much nitrogen. Oops. Creatinine, which we've already mentioned, can be used along with blood urea nitrogen as a marker of renal function. So again, this is the breakdown product of creatine. And it happens spontaneously. And it correlates with muscle mass. So we want to watch for this in particular because when creatinine begins to increase, that can indicate that nephrons are being destroyed. This is very problematic in rhabdomyolysis. So, a little story time. Uh, I actually got rhabdomyolysis in grad school, and I presented with fever, extreme muscle pain that I was trying to shrug off, and eventually nausea, disorientation, and vomiting. So then when I get to the doctors, they take my blood, they check my creatinine, and they look at it and say, oh my gosh, you have rhabdomyolysis. You have very, very high creatine kinase. This creatinine could begin to destroy your nephrons. And basically, the only thing they could do for me, though, was to hook up a bunch of IVs full of water and just pump me full of water to help dilute this in my system. So I had to be there for almost a full 24 hours on IVs. As you can imagine, that's going to make you pee a lot. So I was constantly walking around with a bunch of IVs having to pee. But worth it to keep my kidney function. So this is pretty much everyone's least favorite topic in ZooFizz 3115, but it is important. So this is the nephron. We have an afferent arteriole and an efferent arteriole. Efferent means leaving. Afferent, entering. I always remember A comes before E. You can tell that I am over exaggerating the afferent versus efferent, but otherwise the words sound really familiar or similar. So this is an arteriole, it's carrying blood. This blood then goes into the glomerular capillaries, and these are encapsulated in the Bowman's capsule. This is where the nephron really is this yellow part. So the blood is passing near the glomerula or near the Bowman's capsule, and we are going to perform 4 things: filtration, reabsorption, secretion, and excretion. First, we're going to filter the blood. So it's going to go down, solutes are going to go down their concentration gradient. The blood is going to continue going through the efferent arteriole as it passes by the, oh gosh, I believe this is the jejunal part of the nephron, but I forgot. It gets to the peritubular capillaries. Here, solutes that are needed are reabsorbed, so they're put back into the blood. And we secrete additional things that need to be eliminated. And then eventually, all of the stuff that needs to be eliminated goes to urinary excretion. And this is now deoxygenated blood. And it needs to head back to the lungs. So elevated BUN or BUN typically indicates decreased renal function, and specifically decreased glomerular filtration rate, meaning this concentration gradient, these ones, are not working. The urea is not leaving the blood, so I'm just going to put U's in here. The urea is not leaving the blood, and it's getting carried back in the renal vein because we are not filtering it. It can also be elevated, though, with dehydration because you have less volume. So that is going to make it that so that the concentration gradient is not working because this will have an the blood will have an artificially elevated concentration simply because there's less volume, GI bleeding, congestive heart failure, and excess protein intake. But like, it has to be like really, really excessive, but possible, especially with protein powders. We see decreased blood urea nitrogen in liver disease, overhydration, which you think, oh, how could you be overhydrated? Usually, people who are on illicit drugs, MDMA, general malnutrition, and anabolic steroid use, because that is going to mean more protein is being made into muscle. So less decrease protein breakdown. All right, so now we're going to move to our serum electrolytes. This is a really big topic. There's a lot of reasons serum electrolytes can be altered. We're going to go through their general importance and their relation to nutrition status. So we'll focus on sodium, potassium, and chloride, and calcium. So first up is chloride. This is our primary extracellular anion. Anion means negative. Chloride helps regulate our acid-base balance, so it's basic, osmotic pressure, and fluid distribution, and it often works in conjunction with sodium. So hyperchloremia can lead to alkalosis and hypokalemia, hypokalemia being low potassium. Hyperkalemia we see with kidney disease, overactive thyroid, and cardiovascular disease. So to really understand how bicarbonate, or why bicarbonate, not bicarbonate, I'm sorry, why chloride is important, is actually to think about how bicarbonate works in our blood. So HCO3 minus is bicarbonate. So bicarbonate and chloride enter red blood cells. So this is obviously a red blood cell. In an opposite transport, in a chloride shift. So we need to have enough bicarbonate in the red blood cell so that chloride can come in. We also, though, need bicarbonate in the red blood cell because bicarbonate dissociates back and forth via bicarbonate or via carbonate anhydrase to CO2 and H2O. So basically, we have CO2 from the tissue, and this is from glucose metabolism or fat metabolism. So we need to get rid of that. We pop it into the red blood cell. When it interacts with water, it will dissociate to bicarbonate, and bicarbonate can then be transported into the plasma and chloride comes in. But this has to occur because of a concentration gradient. So we have to have less bicarbonate in the plasma than in the red blood cell. We need to have less chloride in the blood cell than in the plasma. That's why it's extracellular. It's outside the cell. So This chloride shift will help us maintain our acid-base balance. This will also, this transition, so the CO2 can either become bicarbonate. It can also then displace oxygen from hemoglobin. That's what's happening here. And then oxygen in the plasma goes to the tissues. And this CO2 will be exhaled when this red blood cell gets back to the lungs. Additionally, this cation, or hydrogen, will also bind to hemoglobin. And in the presence of oxygen, if it is oxygenated, again, that oxygen is going to go into the plasma, and that's going to go into the tissue. And then we will have this slightly acidic red blood cell because it has an extra hydrogen, but we can always make it back into water and CO2 and then attach it again to the HbA1c, or the HB hemoglobin. But that depends on how much hemoglobin we have. So this is all a very delicate balance. So we need to be able to both excrete, to get absorbed and reabsorb bicarbonate, and we need to be able to regulate chlorine. We primarily regulate chlorine through a combination of bicarbonate, sodium, potassium. Electrolytes are confusing because they are all interrelated. So right now, we're now looking at the kidney. So we're in the loop of Henle. So if we remember, we have our Bowman's capsule. Comes into like a little loop, a distal tubule, and then like that. This isn't a great nephron, but look at your human physiology notes. So we also have, we are going to try to mediate how much sodium, potassium, and chloride. However, so this is going in through the loop of Henle, being absorbed, but it can be blocked by diuretics, or if there's not enough potassium, we then see that sodium and chloride tend to move together because they have opposite charges. Bicarbonate and chloride move in opposite directions because they have the same charge. And this is limited by luminal Cl, so concentration. So this depends on the Cl concentration or chloride concentration. And again, these little brackets mean concentration. So then in the distal tubule, we see that we then will reabsorb whatever sodium we need, and so on and so forth into the collecting duct. You don't need to know the nitty-gritty of this, but please do know that the regulation of chloride depends on bicarbonate, sodium, and potassium, and know generally how they operate in regards to each other. So do they tend to move together, or do they tend to move in opposite directions? So we see abnormal chlorine concentrations when an individual might have primary aldosterone, Cushing's, this HbHs dehydrogenase deficiency, and congenital adrenal disease. So just another way of looking at this. This is a schematic representation of the interactions of chloride and potassium, because as I mentioned way back here, hyperchloremia and hypochloremia are related to kidney disease, and hypokalemia is related to hypochloremia. So this is showing that when we have chloride depletion, not enough, This will lead to potassium depletion. So let's walk through this. Chloride is depleted. So chloride is extracellular. So we don't have enough chloride, so we will have a concentration gradient that's going to lead to a decrease in extracellular fluid volume. A decrease in extracellular fluid volume is going to lead to a decrease in glomerular filtration rate. And because chloride and bicarbonate operate in opposite directions, we're going to see less filtered bicarbonate. So over a long period of time, this is going to lead to a sustained increase in the concentration of bicarbonate in extracellular fluid. So just remember, let's just have a little schematic. So this is a cell. There should be more chloride outside the cell than inside the cell. I made this cell too small. And there should be less bicarbonate outside the cell and more inside. Just assume that there's more in here. But when we don't have enough chloride, that means that we are going to have less extracellular volume. So we'll just make the intercellular volume bigger. And that is going to mean that we'll have excess bicarbonate simply because, well, one, it can't go into the cell opposite to chloride, but also because the volume has been reduced. So recall that a concentration is an amount, so we'll say milligrams over milliliters. If you keep this the same, the top part, but you decrease the bottom part, overall your volume is going, or your concentration is going to increase because your volume decreased. Okay, let's keep walking through this. How is this leading to hypokalemia? Well, so we will see a increase in epithelial sodium channels. So these are Na transport. When we have more sodium channels, particularly in the kidney, then we are going to get more movement of sodium, more, whoops, sorry, my pen just disappeared. We're going to have higher Na delivery and reabsorption, and that is going to lead to higher potassium excretion as well. So that high excretion will lead to depletion. Because of the high excretion, we will downregulate the chlorine because it's linked to the sodium in the loop and early distal tubule. We're going to increase proton secretion. This is going to lower the pH. We'll also see more urea production and excretion because what we're trying to do now is maintain the acid excretion despite alkalosis. And that alkalosis is happening because we don't have enough chlorine, which has a negative charge. And we're getting rid of too much sodium, which has a positive charge, and too much potassium. So now we need to use hydrogen, basically just a proton, which is acidic, and the urea, which is acidic, to try to rebalance our pH. So we are trying to rebalance the pH at the expense of potassium, and that again is going to lead to the hypokalemia. So this is a very interconnected system. Again, you don't need to know every single aspect of this, but do know that chlorine depletion is interrelated to potassium depletion, and that the reason for this interconnected depletion is our body trying to maintain its acid-base balance, and that's going to lead to, we're going to see higher bicarbonate. This is creating the alkalosis. And we have to use other sources of acidic compounds like protons and urea to decrease the alkalosis with an acid. So here's the one people are primarily familiar with, sodium. So we have serum sodium and urinary sodium. Serum sodium is the primary extracellular, outside the cell, cation because it's positive. It helps regulate acid-base balance, osmotic pressure, and fluid distribution. So hypernatremia, too much sodium, is related to dehydration. So it's an extracellular cation. If we decrease the volume in the extracellular compartment, we're going to have hypernatremia. Or if we have excess fluid output, again, lowering the volume. So excess fluid output could be due to diarrhea, sweating, or burns. Hyponatremia can happen when excess sodium is lost from the body, also from vomiting, diarrhea, suctioning, and diuretics. So fluid output can either result in hyper or hyponatremia. Urinary sodium, on the other hand, is a marker of the kidney's ability to excrete sodium. 24-hour urine is reflective of sodium ingested because around 90 to 95% of sodium ingested is excreted in the urine, but it's not valid if sodium is high in the sweat, because that would mean that a lot of sodium is being lost through the sweat. That would indicate potentially hypokalemia, usually with hypochloremia, because of all the reasons we just talked about. Unless they are on a potassium supplement or aspiring diuretic, we also see this high Na in sweat in cystic fibrosis. And this is actually due to the inability of chlorine to move correctly. So let's walk through sodium homeostasis. Let's start at homeostasis. We have normal sodium concentration in the extracellular fluid. So again, let's make an extracellular fluid. We'll make a cell in it. So that means we have more sodium outside than inside, because it's the primary extracellular cation. If homeostasis is disturbed and we have too much sodium in the extracellular fluid, so now we have a lot, too much, we're going to stimulate osmotic receptors. How we do that? Antidiuretic hormone, aka vasopressin. And this is going to make us thirsty. We're going to drink water. We're going to decrease how much water is lost in urine. So we'll increase net water gain. So we aren't necessarily losing any sodium. We're diluting our extracellular fluid with more water. So basically, now we have this situation. We have two NAs in here, and now we have a lot of H2O out here. And we have the same amount of high sodium, but it's being balanced with the H2O. So it doesn't want to move into the cell because the H2O is balancing in between the cell and the extracellular fluid. So now let's say we have the opposite problem. And we don't have enough sodium in the extracellular fluid. We have decreased sodium concentration. Osmoreceptors will be inhibited. This is going to decrease ADH, and we won't be thirsty. We are going to have to pee. And so again, this is going to mean that, actually, let me just erase my little guys here. We're going to pee. We're going to have that water taken out until we're back to a balance. So 2 on the inside, 2 on the outside, even though there should be more on the outside, but this is just an illustration.